Alright guys, we're back. Video number 4 in the 12 lead series. And let's start talking about what you're going to be seeing as far as damage on the 12 lead. Okay? And again, we're going to do this a couple of times actually. Actually 4, 5, and 6 are kind of going to start blending together here. That's okay. Because it's really important that you understand what you're looking at. Alright? So when we're talking about diseased findings, we're going to start talking about the things that we will find. And it's very important that you understand the difference between ischemia, injury, and infarction. Okay? Injury. Ischemia means that there is a area, a zone in which, and then we're talking about this one right here, the zone in which there's a hypoxic state. Okay, it's actually a very early sign, but this is the area that is a little bit deoxygenated. This one has been without oxygen for way too long, which is your area of myocardial injury. The third one, which is the really bad one, of course, is where you actually have dead tissue. Okay, infarcted tissue. It causes a deep Q wave, and it results in the absence of depolarization. This part of the muscle does not move, and it is so very important to understand that. There we go. Sorry guys, had to hit my lights again. Now, again, what we want to do is we want to catch it long before it gets to this stage. Now, is that it possible? Sometimes that answer is yes. Can we reverse it sometimes? Every now and then we get lucky and we can, okay? The way that we truly reverse it is we open up that coronary artery and we get them to the proper place, all right? So you have to understand, by the way, and this is the progression. You have a T-wave inversion when you usually have ischemia, okay? When you have ischemia, you have a T-wave inversion. As the injury progresses, it then becomes the ST elevation. That's where we're actually having hypoxic tissue, okay? And then when it finally does die, that's when you end up getting a deep Q wave, and you actually get a T wave depression out of that, okay? XT segment depression. So what we're actually looking for, guys, is the ischemia. We're looking for an inverted T wave at that point. If I'm seeing something with an inverted T wave, I really start to think maybe I've got something else going on here. And it's two congruent leads, and we're going to talk about what is congruent when we start talking about Isal. Isal's on the way, guys. You guys are going to learn what Isal is. You're going to be able to spot Isal in your sleep. So injury is a 1 millimeter in two congruent leads where you have ST elevation, and it's very important to point out here. Your J point is what determines the ST elevation or depression. And you only need one box, 1 millivolt of change in order to find that. Greater than 2, by the way, in the septal leads. The septal leads take a little bit more to indicate that there's damage going on. And we'll talk about which leads are which. Again, pathologic, I've got dead tissue. The Q wave is bigger than 0.4 seconds, or 1/3 of the width of the R wave, okay? And again, notice how I've got damage already with this guy, okay? So long and the short is they started like this, and then they end up going in this nature, okay? And it's how we can tell, how do I tell whether it's a STEMI or a non-STEMI? Okay, again, the ones that are easy are these myocardial injuries where you've got massive elevations. You only need a slight bit of elevation to actually call this an ST elevation MI. Now, again, normal heart muscle usually starts with a subendocardial injury. And again, no cell death is actually occurring at this point. So the first several hours, again, you might have the pain. But look at the difference in the first day of the progression, okay? So look at this. Everything is normal on that one, but then they start having damage, and that's when you get this ST elevation. You get a little bit of peaking of the T waves. And then when you get the ischemia, again, you're going to see a whole lot of ST elevation, okay? So this is probably going on for longer than 2 to 3 hours at that point, okay? Which is kind of the spooky part. And now, again, it can keep going, and you can continue to have damage after 2 days. Usually after 2 days, you have a complete change and a complete death. At that point, they actually stop hurting. It's usually because they can't stand up, or they're dizzy, or they're weak, and again, after several months, by the way, that tissue gets replaced by scar tissue, and it will actually bulge out. And when it bulges too far, of course, when it gets and then you add additional pressure to it, it can cause a ventricular aneurysm. The heart simply, for lack of a better term, it blows out. I mean, all Mortal Kombat style. Boom, there it goes. Okay, so the thing is here. Notice after 2 to 3 days, you've got the damage already done, and you've got a deep T-wave inversion, and then the ST may be at baseline. I can tell you, usually, guys, the ST is normally on an infarct is usually down here on these guys. Okay, it's usually down there, and it's usually the area that's affected. Now, you're saying, great, I know how to tell it now. Not so fast, gang. And we'll talk about the changes that are involved with that. So again, if they have an inside the infarct, again, you can have ST elevation or depression depending on where it is, okay? The noted thing is the ST elevation or the ST depression. And then the first few hours, we can actually see this. By the way, and this has a lot to do with the camera view, okay? This has almost everything to do with the camera view here. So looking at it one way, I might have that again, that might have that real high ST change. If I look at it from this direction, and I got to put my camera up here, I might end up having a P, and let's say the QRS, and then, but the T wave will be depressed or inverted. Now, probably the more correct way to do that is probably the more correct way to draw that would be like so. Go back to my red here. Again, I got my P wave, I got my QRS. Probably going to be a big QRS. And then you got ST depression. All right. Again, a depressed ST segment here. Okay. So based on that camera view, I'm looking at depression. Looking at this camera view, I'm looking at elevation. Wait a minute. That doesn't make any sense. Now, can I have one without the other? And that's one of the tricky things. Once that tissue dies, gang, actually I get T-wave inversion or ST returns to baseline, or worse yet, I can have permanent ST depression down here. So the person's ST can be like so. Now, again, do I know if it's an old infarct or a new infarct? Probably your best way to figure that part out is to say to your patient, hey, what kind of cardiac history do you have? It's amazing what they can probably already know. If they tell you that they've had a heart attack, you can expect there to be changes there, and maybe not be as panicked as you would be if I'm looking at it for the first time and go, oh. But again, the lesions usually heal, and it involves the entire thickness. It doesn't usually. But what do you think happens physiologically at this point? Do I get the same amount of squeeze and push out of this? And my answer to that is absolutely not, because again, you lose that, and therefore you lose ejection fraction. Okay? Now, your body has wonderful ways to compensate and heal. Your doctors have the amazing ability to prescribe medications to help do that. Now, speaking of Isal, and we're going to sum this up on another little part that we're going to do. So where is it that I'm looking at injuries and I can tell where it's actually happening? Okay. Now, I'm going to tell you right now, you can pay attention to this chart, but I've got a lot better way to show this and to have this make a lot more sense. Let's talk about the anterior one first. The anterior wall of the heart, by the way, is usually your left anterior descending branch of your left coronary artery, okay? And I would probably remember that little factoid. That's kind of an important factoid. You might want to remember that one. So what does that mean exactly? That means that this part of the heart is actually dying, the anterior wall. Now, let's go to a special degree of stupid here. V1, V2. Matter of fact, I'm gonna change pen colors here and say ink color. Let's go to this right here. So I got V1, V2, V3, V4, and then 5 and 6 are actually over here on the sides. Okay. So what would I see as far as damage? Now, would I see any damage on the bipolar or unipolar leads? No, not really. I might again see a little bit of T-wave inversion on lead 1 and subtle finding. But the big one is here, am I seeing ST elevations and depressions in these leads right here? V3, V4, okay? So again, if I've got significant, there are going to be Q waves that are significant, but the biggest thing is I'm going to have ST elevations V3, V4. So again, anterior wall MI, that's where we're seeing the damages. So again, if I'm looking at the anterior leads, and we're going to mark this as an A. Hey, this is starting to look. By the way, so for those of you that are really wanting to jump ahead, this is the septal wall, but I will also tell you that this is part of the anterior wall. Okay, and then this is part of the lower lateral wall. Okay, hey, there's your Sal. Well, where's the eye at? Well, it's really simple. The inferior leads of the heart are these guys right here. Okay, so 2, 3, and AVF, or as we like to call them, the boot. Okay, now, if you can remember that these guys here, the anterior wall, septal wall, lateral wall, the only other two that you need to remember is these two guys right here. That's also the lateral wall, but I will tell you that that's like the upper lateral wall, okay? Let me explain what I mean here. I click ahead. So the anterior lateral wall, okay? So it's not only affecting here, but it's also affecting the side wall of the heart, okay? So when I'm going to have ST elevations, I'm going to have them, again, I'm going to have them in my lateral leads. Notice how my lateral leads, this one's kind of changing, kind of weird, okay? You may have them in these guys, but usually your anterior lateral wall is fed off of this artery right here, your left circumflex artery, okay? So your lateral wall, again, more than likely the lower lateral leads, and look at the elevations on this guy, yeah. All right, so your anterior lateral leads, again, the A's, the A's, the L's, all right? So again, so anterior lateral leads are right here. Again, V1, AVL, V5, V6, okay? Now, I would say that the anterior lateral leads also include 3 and 4, especially the anterior part of it. So if you're seeing damage in both of them, that's when you call it an anterior lateral. I usually just call it lateral leads, okay? Keep it simple. Lateral leads, all right? So lateral and high laterals, again, this is the very side. Usually it's the first branch coming off of the circumflex artery that is catching towards the back, the main pumping chambers of the heart. And those guys are, again, V5, V6, the lower laterals. If it's higher up on the wall, you're going to see damage. Remember when I said that it was upper? This is where the high lateral or upper lateral leads, that's where they're talking about. Inferior and inferior laterals. This is usually off of one of two arteries. The proximal branch of the left circumflex, which is the part that goes here and it goes down to the back wall. But the big one here, the right coronary artery, is blocked in some way, shape, or form. And as you can see, you've got several branches coming off of the right coronary artery, okay? Now, the problem with this is that this one is the main feeder of the right wall of the heart. So if I'm having damage going on to the right wall of my heart, I lose my pumping action to the lungs, and it starts to back up in the body. Again, major problems there. By the way, the other part of the anterior wall that can be affected by the inferior wall is this guy down here, which is fed by the distal end of the left coronary artery. Okay? Very important to understand that. But your inferior leads, hey, there's the boot, all right? So if they say inferior lateral, backing up here, if they say inferior lateral, all right, so they're actually talking about more of this area of the heart versus that area of the heart, all right? This is your inferior leads. This is your inferior lateral leads. Usually it's going to be more V6. I still think that this guy is still a little bit involved with it. Now, if I have a true posterior, I'm seeing damage, and what we're looking at here, guys, is the back wall of the heart, okay? So, again, this is the circumflex coming here, and then, again, this is your great coronary vein that's dumping back into the right atrium. But what's happening is you've got a distal occlusion of the left circumflex artery in the back part of the heart, or one of the branches coming off of the right coronary artery can also do this, okay? Now, what does that mean for us? We see depressions everywhere. And by the way, these pictures are horrible as far as that. I see depressions everywhere, and I don't see any elevations, all right? And I'm going to tell you, we're going to do very specifically talk about how we're going to find these by doing the 15 lead, okay? So when we get to there, that's what we're going to be looking for, is this posterior damage, okay? And let's see here, erase them all, and I'm changing back to the pen. I don't like the red. Let's go back to the red. All right. So your true posterior leads, by the way, I'm seeing depressions everywhere, okay? And I'm going to see reciprocal changes there. I'm going to see ST depressions, all right? Well, what are reciprocal changes? And I'm going to dive into that on the matter of fact the very next video, so hold that thought. So let's apply the little Isal mnemonic that we've just learned, and we'll talk about it. Guys, I'm actually going to give you an overlay. All right? And I'm going to give you an overlay with, it's actually color coordinated. So when we start looking at what is what, as far as where the damage might be going on with a STEMI, it is so very important that you guys actually understand that. And what I'm doing right now is and if you're not, as you start to learn this, please feel free to do so. Notice how I'm using the old colored ink here, and I'm using it definitely on purpose, because I want you to make sure that you see what leads go with what, okay? What leads go with what, all right? And memo to me, don't use orange ever again. Let's see here. I like the, how about green? Yeah, let's do green. All right. There's our green. There's our green. And I'm going to kind of subdo the green around this guy. Sort of, kind of. He's kind of like a hybrid. All right. So when you start looking at a 12 lead, what I want you to do is take a good, solid look at your leads and where you're seeing elevations. Okay? So I'm going to find my baseline, right? Because remember how we find our baseline. This guy right here. I'm going to find my baseline. I've got elevations here because the ST segment's way high. I got right here, it's really high. And right here, it's really high. Okay. So as we all know, these are the anterior leads. These are all anterior leads. Guess what? By the way, so these guys right here, again, and I'm going to put my ink color as black here. So these are the inferior leads. All my blues, by the way, were the lateral leads. Okay, laterals. And these are my septal walls, but this one's septal anterior. So I got elevations in all of the anterior leads. I have an acute anterior wall infarction. Not only do I have an anterior wall on this one, but notice that the ST segments are elevated here. Guys, one thing I would do if I were y'all, as you're starting to learn this, circle your J point, okay? Circle the J points, all right? Especially if I'm not sure. If I see elevation, I circle it, okay? There we go. Look at all those I just circled. And then I apply that little chart. Okay, oh, that was a lateral, that's a lateral, this is a lateral, this is a lateral. Hey, this is my anterior, this is my interior, this is my anterior. All right, and if I back over to here, when we were talking about anterior leads, remember when I said, so basically the part of the heart that's being damaged right here is all of this and all of this. I'm thinking that that blockage is somewhere up in this general area. But look how much damage that guy's got going on, okay? Matter of fact, it's actually up in here as well. Not good, right? What do you think is going to probably do to the pumping action of this guy's heart? This guy's going to have a very decreased, this guy's going to definitely be hypotensive. And with all of that injury that's going on, I would expect some dysrhythmias to start happening. All right. Going back fast forward here. All right, so an acute inferior wall MI, okay? I'm going to circle my elevations. Hey, look at that, 2-3 AVF. Hey, we talked about that earlier. That's the inferior walls, right? Now, do I have any other walls that are involved? No, I don't really have any other, a little bit here, right? A little bit here, right? Probably like one box here. I've got one box here, okay? Now, relating that back to the heart, right, inferior wall, but I probably have some of this going on right there, okay? So probably his damage is going on because of some sort of blockage in this general area of the heart. What can I expect? If this all area gets irritated, would I expect that patient to go into ventricular tachycardia? Would I expect him to become shocky? Absolutely. Does this affect the right wall of the heart? Probably, because again, or it could be more than one vessel has been placed into trouble with this point. Now, again, the key things I want you to take away from this. This was kind of a little introduction to Isal, but anytime, guys, that we're looking at a 12 lead, circle where you see ST elevations. Okay, 2 or more contiguous leads. If they're in the same grouping, the same colored, if you will, these are contiguous leads, all right? And that if they're together, that means that, guess what? You've got a damage to a vessel that's going on. If I've got one in lead 2 and then I've got lead 4, I know that these guys don't match up. But 2, 3, and AVF, they definitely match up. All right, that does it for this one. We got a lot more material to cover, so I'm going to see you guys on the next video.